Hello and welcome to our session today. Today we are going to focus on moderate sedation. This is a crucial aspect of patient care that plays a significant role in various healthcare settings. So, as nursing students, we need to understand what moderate sedation is because of its significance in our journey towards becoming proficient healthcare workers. So, moderate sedation can also be referred to as conscious sedation, and this is usually a controlled state of reduced consciousness that will allow patients to be able to tolerate unpleasant procedures while maintaining the ability to independently maintain their airway and respond to physical or verbal stimulation. So this is usually a very delicate balance between keeping the patient comfortable and ensuring their safety throughout the medical procedure. So we have to really know what's moderate sedation and what is anesthesia, because someone will be able to ask us those two questions. And we need to tell them that while moderate sedation is a drug-induced depression of consciousness, during which patients are able to respond to purposeful verbal commands either alone or accompanied by light stimulation. Anesthesia, on the other hand, is nearly unconscious and only has a purposeful response to repeated and painful stimulation. So in anesthesia, the patient may need assistance with breathing, but cardiovascular function is usually unimpaired. So, general anesthesia, the patient will be completely unconscious and will not be able to respond to any form of the level. So we have to know what's moderate sedation. Of course, we have already said that it's the same as conscious sedation, but it's different from anesthesia, okay, in both partial and full anesthesia. All right? Okay, guys. So we have some procedures that require moderate sedation, and we could list them like when you check the first one, we have the synchronized cardioversion. Of course, this is similar to electrical defibrillation, and in that there is normally a thoracic electrical current that is applied in the anterior chest, right? We'll have the anterior chest to terminate a life-threatening or unstable tachycardic arrhythmia. Okay, so this is one of the procedure that may require some level of sedation. Number two, we have that chest tube insertion. So for the chest tube insertion, you find that a thoracotomy or a thoracostomy tube will be placed between the mid to anterior axillary line in the fourth intercostal space, tracking above the ribs so that not to injure the intercostal bundle that consists of the artery, vein, and the nerve. Usually the fourth intercostal space is normally at the nipple level for the females and the inflammatory fold for the females. Another procedure that may require some level of sedation is endoscopy, okay, like the esophagogastroduodenoscopy, EGD. In endoscopy, you find that this is the procedure that is usually done just to examine the body's tissues inside somebody. Okay, so during endoscopy, the healthcare provider could place an endoscope, which is just but a long thin tube inside the body, and it should reach the place where they are really interested. So most endoscopes usually have a light and special camera for at least for that visualization. Typically minimally invasive, but it can so it can be done through the mouth, the anus, or any other incision. All right. Another procedure where we could have minimal sedation are interventional radiographies. So like angiography, we have angioplasty, embolization, gastrostomy tubes, intravascular ultrasound, stent placement, foreign body removal, or needle biopsy. Lastly, we also have interventional cardiology, which is the other procedure that could require some moderate sedation. So catheters here are usually very small that are similar to the IV that will be put through the patient's blood vessels. So this is why we don't need an incision for the procedure that uses the catheter. So that gives us another procedure where we'll need moderate sedation. All right. The next is that now, after looking at all these procedures that will require moderate sedation, we can now look at the continuum of sedation. Okay, so according to the American Society of Anesthesiologists, there are 4 levels of continuum of medically induced sedation. Right, and remember, in minimal sedation, this one allows the patient to respond normally to verbal commands, so there is no anything to worry about that. But it does not compromise respiratory nor the cardiovascular function, right? Function in that case. This may affect cognition or coordination, and we have the 4 levels on the continuum, where we have moderate sedation, right? Moderate sedation. So I find so looking at moderate sedation, then we have deep analgesia, and lastly the general anesthesia. Looking at the AVPU technique, you find that in terms of responsiveness, moderate sedation they'll be alert, right? In terms of responsiveness for moderate, they will have verbal stimuli, they could respond to verbal, or for a deep, they could respond to painful stimuli, and for general anesthesia, they are generally unresponsive. Okay. Ventilation will not be unaffected in minimal, they'll be adequate, or sometimes maybe inadequate or frequently inadequate for general anesthesia. For the cardiovascular is unaffected in the minimal sedation. Moderate sedation is, of course, maintained, usually maintained in deep and may be impaired in general anesthesia. So we have those 4 levels on the continuum. All right. So, guys, I have a question here. So, what are the 3 objectives of procedural sedation? What should this be? Maintenance of consciousness and cooperation, minimal variation in vital signs, safe return to baseline, pain prevention. Okay, guys. I'm happy that you have picked option D, and I'll be able to explain why this is the odd one. Okay, the odd one, right? So this one should have been picked as the correct answers: A, B, and C. Okay, remember, even in sedated patient, they do experience pain, since administration of sedatives alone does not mean that the patient will have a pain-free experience during the procedure, right? So D makes is odd, and it's wrong in that case, right? General objectives for patients receiving sedation for procedure will have alteration of level of consciousness, maintenance of consciousness, maintaining cooperation, encouraging cooperation, evaluation of pain threshold, minimum variation, and you have rapid return of amnesia and set return to baseline, right? Remember, the desired procedural sedation is you should have a patient who is relaxed, a patient who is cooperative, and a safe patient. All right, guys. So we have some benefits and risk associated with moderate sedation. We have to start, of course, with the desired, where we normally have at least a relaxation. Patient is able to cooperate during the procedure, so this gives ample time to the physicians and healthcare provider in assisting the patient. We could also have purposeful responses in verbal communication and tactile stimulation, which are very vital for body control, and also easy arousal from the sleep. Remember, we are moving from the minimal sedation to the general anesthesia. Okay, for the minimal sedation, moderate sedation, at least we can be able to arouse the patient from sleep. Okay. All right. What about the risks, guys? So we have several risks associated with sedation. First of all, we could have deep unarousable sleep. A patient could suffer from hypotension, bradycardic. Some could be agitated and combative, and could also suffer from hypotension, respiratory depression, airway obstruction, and apnea. Remember, as you also provide the sedation, you need also to be aiming for adequate pain control, okay, which should be part of the sedation and planning and evaluation. All right. So we have phases of sedation, and there are majorly three. Phase one includes the pre-sedation assessment. Okay, so the healthcare provider will have to take the patient history and the current cardiac, pulmonary, and neurological status. The nurse will go ahead and also assess the level of anxiety, if there is the NPO status, and so that we can be able at least to double check the patient condition against this baseline data that you have. Remember, prior to initiating sedation, we need to document vital signs. What is the level of consciousness, the SpO2, the endol, and then we have to ensure that you have stable IV access just for in case of resuscitation and in case of reversal of any overdose that is required. So we have some equipment that will help in monitoring and monitoring. We have the oxygen and oxygen delivery devices, the flow meters, nasal cannulas, face masks. Could also have the suction, the manual resuscitation bag, valve mask, artificial airways, including oral, nasal in appropriate sizes. Then you have intubation equipment, the endotracheal tubes, laryngoscopes, and the stylets, pulse oximeters, cardiac monitors, the ECGs, and the non-invasive BP monitors, the AT monitoring equipment for that case. All right. Okay, guys. So question time, guys. Let's have some fun now. All right. Okay. Which two items must be added to an equipment list for moderate sedation? For moderate sedation administration. All right. Okay, so NAS A says central line insertion kit. NAS B says urinary catheter. NAS C says ATE monitoring equipment. And NAS D says intubation equipment. Okay, guys, they are talking of two items, and I'm happy you are working with NAS C and D according just to our previous presentation that we had. All right, in that case. Okay, great, guys. So before the procedure begins, we have some 3 steps that have to be undertaken. Which are these 3 steps? Which are these 3 steps? Okay, NAS A says site marking, NAS B timeout, NAS C team member introduction, NAS D says verification of patient identification. Remember, the universal protocol is designed to prevent rare but disastrous events of wrong patient, wrong site, wrong procedure. Okay, so marking, that is correct. Timeout, that is correct. The verification of patient identification will help at least avoid the wrong patient. All right. Okay, guys. So NAS C is the one that is odd. Okay, this one is odd. All right, guys. So we have a pre-procedure verification where you ensure that all documents are complete. You could have the patient or the family verify the type of procedure to be performed if possible, and depends on the circumstance. If it's an emergency, the patient is unconscious, the family will be very key at this stage. Okay. Patient is properly identified so that we have the right patient at all time. Remember, before you need to have a suctioning, which will have size appropriate catheters, and they should be functioning. Should have oxygen, which should be adequate. airway sizes, which could be of different sizes, and pharmaceutical agents that you need to use, then the monitors, and then the equipment for that case. So site marking is very important. You have to mark the site when there is when there is any question of laterality, okay, right or left or multiple levels. Okay, here you have our site here that has been marked for that case. Timeout is very important. You have to perform immediately before the start of an invasive procedure. You have to validate team member agreement that correct procedure is being performed on the correct patient. Procedure may not proceed until members of the team are in agreement. So before you administer a sedative, you have to remember what? Timeout must be done. Okay? Okay guys, time for a quiz again. Which two assessments need to be performed prior to the start of the procedure? NPS status assessment, post-discharge need assessment, physical assessment, and psychosocial assessment. Psychosocial assessment, guys? No, really. We're looking at physical assessment that will either help us identify the site that has been marked, all right? And that will be so key, okay? And also NPO status should have to be determined so that we are able to know which kind of patient we are dealing with, okay? So A and C in this case were the right nurses with the right information to us. So in most cases, this sedative, they are normally given IV. So we have IV bolus administration, which is the most common method and the route of sedation administration in critical care. So this normally allows for smaller dosage of drugs to obtain the desired effect and prevent over-sedation. So we have different classes of medication that are commonly used in critical care setting. Outside the antithrombotic agents and cardiovascular agent, cardiovascular drugs and antithrombotic agents, these are the most commonly used ICU drugs, okay? But outside that, we have these moderate sedatives that we can use: benzodiazepine, opioid, narcotics. We have hypnotic sedatives, dissociative agents, and barbiturates. Remember, barbiturates are used commonly in sedating children, okay, for that case. So for the other four, at least we'll be able to see them and how they are used now in the adults. All right. Okay, so starting with barbiturates, of course, the most common one, we have the short-acting one, like the midazolam. Midazolam is a short-acting. Intermediate-acting one is what we refer to as the lorazepam, and then the long-acting is the diazepam. Okay, the one that we normally use, the Valium. Okay, the Valium, the commonly used known one, or is the Valium. Okay, so that's what you need to know about these benzodiazepams. This medication, they have anxiolytic and amnesic properties, okay? However, they can cause respiratory depression, increased pulmonary resistance, decreased ventilator response to increasing carbon dioxide. So cardiac depression may also be mild to profound, depending on the underlying cardiac status of the patient. They can also increase the effect of other cardiac medication. So they have to be used with that question. However, if you have an overdose, you can reverse it using the fluminazole, okay, and you can be able to get it. It's commonly with this trade name, that is the romazicone for that case. We could do multiple doses, may be necessary depending on the half-life of the sedative, and the patient may need to be monitored longer. So administration of a reversed agent is normally referred, or is normally considered an adverse event for that case, and has to be documented appropriately. Next, we have the narcotics or the opioids. The most common medication here, we have morphine and the fentanyl, okay? morphine and mefentynyl. This medication, they provide pain relief as needed throughout the procedure, and they are usually administered in combination with other sedative agent. All right, you risk producing bradycardia in patients, patient being hypotensive and even suffering from respiratory depression when they use the opioids. Intravenous fentanyl is given rapidly may cause chest wall rigidity. Okay, chest wall rigidity with the tight muscles of ventilation, impairing ventilation. So this life-threatening and is titrated with shorter-acting neuromuscular blocking agent, okay, such as the succinyl. We have the succinyl chloride, and this will allow for ventilation by intubation and bag ventilation, or by bag and valve mask until the patient has achieved adequate ventilation. We could reverse it using the naloxone, okay, like here the naloxone nasal spray. So if this opioid has a long half-life, multiple dosage may be also be necessary, as naloxone is a short-acting, okay, naloxone is a short-acting neuromuscular blocking agent. The patient may need to be monitored longer. That's what it will mean. Then administration of this reversal agent, as we have considered in the other parts, is an adverse event, okay, and has to be treated as such. Next, we have the hypnotic sedatives, and the common drug used here is the propofol, right? Propofol injection emulsion. It's used for short half-life and a rapid awakening from sedative, and it has no analgesic effect, right? It has no analgesic effect. Is normally classified as an anesthesia induction agent. It must be administered by healthcare provider who has hospital privileges for providing this deep sedation. Cardiac effects may include hypotension, decreased cardiac output, dysrhythmias. Respiratory depression will depend on the dosage. There is no agent that can be used to reverse the effects of propofol, but we have at least it has an advantage, okay, because this drug has a short half-life of between 5 to 10 minutes, okay, following discontinuation, so it can easily be cleared, right? Lastly, we have the dissociative agents, and dissociative agents, we have ketamine is the most common drug here, and this ketamine is a synthetic nervous system stimulant. It normally produces both analgesic and amnesic effect. When used, it could produce increased heart rate, cardiac output, myocardial oxygen consumption, and should also be used with caution in patients with underlying cardiac history. This drug is capable of producing bronchodilation but no respiratory depression for that case, and that could be advantage in that case, okay? So the drug will prevent the attachment of the glutamate to its receptors for that case, okay? Once the glutamate is released, it will prevent that attachment, right? So it normally disrupts the excitatory inhibitory balance, okay, for that case, right? Okay. So the reversal agents, that there's no agent to reverse the effects of ketamine, right? But a quiet environment may be helpful in recovery, okay, and it can help reduce the risk of emergence of delirium, okay, because that's what this drug is associated with, okay? So the NMDA neurons are prevented from the attachment of those sites, all right? Okay, guys. Remember, if you have any concerns about your patient, you have to address them. You have to address those concerns and suggestions clearly to the healthcare providers so that they can be able to see how to assist your patient. Okay, remember, you are the patient advocate. And in doing so, you can use the COOS mnemonic where you express your concern, how uncomfortable you are, or we supposed to be made to ensure that the patient or the safety of the patient is guaranteed for that case. Okay, you could be concerned of what has happened, you could be uncomfortable with what is happening, and you should show us how the patient safety could be maintained, all right, so that at least your patient can be assisted for that case. Phase 2 is all about patient monitoring. So during this procedure, the monitoring nurse will evaluate the patient's level of sedation and potential risk to patient safety throughout. Assessments are then documented. Vital signs are normally recorded at minimum of every between 5 to 15 minutes. Documentation is normally made every time a dose of sedation or pain medication is administered, and more frequently if the patient is unstable. So if the patient becomes restless or agitated, you suspect hypoxemia, and therefore you have to assess the heart rate, you have to assess the respiratory rates, the effort, SpO2, and the patient responsiveness. Also evaluate for gagging, nausea, vomiting, and this could lead to aspiration. Okay, this could be leading to aspiration for that case. We also have sedation scales that we have used, and so far in ICU we are having two valid and reliable sedation scales. That is the Richmond sedation scale, right, which has all the values here, where we are going to have it will range from -5 to +4, right? So if a patient is violent and is posing immediate danger to staff, that will be comparative mode, that will be given or awarded +4. If the patient is pulling or removing tubes or catheters and very aggressive, that will be very agitated, +3. Where there is frequent non-purposeful movement, fights the ventilator, agitated, that is +2. Then if is anxious, apprehensive, but movements not aggressive or vigorous, that will be restless, and that will be a +1. Okay, if it's alert and calm, that is 0. Okay, and that is for a normal patient, typical patient, okay, like you and me at rest, will be alert and calm. If they are drowsy, that is not fully alert but has sustained awakening to voice, e.g. eye opening and contact for more than 10 seconds, we could say -1. If they are experiencing light sedation, that is briefly awakens to voice, okay, that's eye opening and contact less than 10 seconds, we could say that's -2. If they're having moderate sedation of -3, that means then movement or eye opening to voice but no eye contact. -4, that will be deep sedation, where there will be no response to voice but movements or eye movements to physical stimulation. -5 will be anaerousable, and here there will be no response to voice or physical stimulation. So for the Rica sedation agitation scale, this one, it normally ranges from 7 +1 to +7, where +7 is for dangerous agitation. This is a patient who is pulling at endotracheal tube, trying to strike at staff and thrashing side to side, all right. A very agitated patient will be graded 6, and this is a patient who does not calm despite frequent verbal commands, right? Biting the ETT, right? An agitated patient of +5 is the one who is who is anxious and mildly agitated, attempting to sit, right? While a calm and a cooperative patient of score 4 is the one who is calm and awakens easily, follows commands. For 3 is a sedated one who is difficult to arouse, awakens to verbal stimuli and follows simple commands, while a very sedated is the one who is aroused to physical stimuli but does not communicate spontaneously. An arousable who will be given grade score 1 is having minimal or no response to noxious stimuli, right? Okay, guys. Remember, you as a nurse, you've just arrived to assist a healthcare provider administer medications. So which items will you monitor or reassess every 5 minutes? Okay, after sedation. Okay, SpO2, vital sign, the agitation and pain, right? And the ETT, okay? So this should be the 4 items for yourself, okay? Urinary output is is important, but it could not be a priority within the 5 minutes, okay? Okay, fine. Phase 3 is about the monitoring and the third phase of procedural sedation, which is the post-sedation care. Okay, remember we had the 3 phases, this is the third one. So here we have to monitor our goals and we monitor against our time. So we have to look for the complications. First complication is about the over-sedation care, which should be taken not to move to the level of deep sedation. Remember, over-sedated patient may be given a reversal agent, okay? So oxygen, ventilation, or hemodynamic stability support may be also offered for this particular patient. As for the under sedation, we could have additional medication may be required to maintain the desired state of sedation. While hypoventilation, and of course this is more associated with the opioids and benzodiazepine. So in this case, you could use a reversal agent. Beside, you provide oxygen and also ventilation support. For the hypotension, which is more associated with the sedatives administration, you could have limited fluid bolus may be given for that particular patient. As for the arrhythmia, these arrhythmias you manage according to guidelines. Remember to determine the cause and the intervention, okay? A link will be popping up on the different types of arrhythmias and how they are managed. Remember, for the sedation reversal agent, we have already indicated flumazine is for the diazepines, while the naloxone is for the opioids. There is no reversal agent for the sedatives and hypnotics, nor the dissociative agents like the ketamine. Okay, reversal agents needed to avoid continuing and worsening adverse effects. So you give the reverse agents in order to avoid the worsening adverse effects of that particular drugs. Okay, guys, so we have a question here, and the question reads that which of the following medication for procedural sedations are commonly used in adults? Remember, we have indicated that there's only one group of drug that is commonly used in children, and that is barbiturates. Barbiturates are the ones which are odd, but the others, benzodiazepine, hypnotic sedatives, dissociative agents, opioids, and narcotics will be used in adults for this moderate sedation. Okay. Which of the following are the potential complications of procedural sedation? Guys, we have looked at several complications, including hypoventilation, oversedation, hypotension, and dysrhythmias, right? It's only laryngospasm that will be odd in this case, okay? So the other ones should be documented as the main ones, guys. Okay, guys, thank you so much. We have come to the end of our session about the sedation, okay? Moderate sedation, okay? Remember that understanding the principle of moderate sedation involves more than just administering the medication. It requires keen observation skills, meticulous assessment, effective communication with both the patients and other members of the healthcare teams. So we must be vigilant in monitoring our patient responses to sedatives, assessing their level of sedation, respiratory status, and the overall well-being. Additionally, we must be prepared to intervene swiftly in the event of any complications like the one that we have mentioned. So this will include being more proficient in airway management techniques, possessing the ability to recognize signs of respiratory depression or other adverse effects, and knowing how to initiate appropriate intervention promptly. Moreover, as advocates to our patients, we must